And when you're evaluating someone for possible Sjogren's, what's your go-to diagnostic framework? Like, what labs and studies do you order? And is there a specific order?
Yeah. So if somebody comes into me, let's say, they're coming to the clinic, hey, I'm wondering if I have Sjogren's. We get that question. It's definitely in rheumatology, you got to start with a very thorough history. I want to know everything. We do a very thorough physical exam. And then in terms of labs, we start with a variety of labs. We start with something called CBC, looking at blood counts. Many patients with Sjogren's will have low blood counts. And we look at kidney function, liver function, because organs can be involved. And then we do something called our ANA or anti-nuclear antibody testing, and we run something called an ENA panel, which are more specific blood tests for Sjogren's. We'll often look at inflammatory markers to see if they're elevated, complement levels. Those can be low if someone has active Sjogren's. Is a good starting place. There is further testing you can do if needed, but that's definitely where I would start.
And how do you handle cases that are antibody negative or don't meet full classification criteria but feel like Sjogren's clinically?
Yeah, these are great questions. And again, I probably get asked this multiple times in my clinic. This comes up a lot. So there's a few ways to approach it. I tell my patients, if you clinically fit the mold, then we say, suspicious for Sjogren's. And a lot of these times I can still manage similarly with or without a clear diagnosis. But a clear diagnosis is important for a lot of reasons. One, it's often important to the patient to know exactly what they have. And then two, sometimes it may change my management. And in those cases, you have a few options. We're looking at earlier antibodies or serological testing. You can even do a salivary gland biopsy to really get a true diagnostic answer. And that be something I have a conversation with the patient.
Mhm. And are there any common mistakes or missed opportunities you see from referring clinicians?
I find that it could be very easy for dry eyes and dry mouth and kind of non-specific symptoms, which are fatigue, brain fog, joint pain, to be overlooked. So yes, I can definitely see how someone may go to some of the other clinicians or providers and report these symptoms, and people may often say, oh, well, it could be our medications, drink some more water, it may be perimenopause. I get that one a lot. So because they're so kind of non-specific, it's very easy for these symptoms to go missed and this diagnosis to take a long time to get to.
Hmm.